Welcome to the Anomaly Talk. This is our first official podcast. My co-host over here, I've got Lawrence, Gabriel, myself, Mina, Morcos, and today we've got a very, very special guest. Welcome aboard, Mina Rofail. This is our first episode. Thank you so much for being here.
Thank you, Mina.
This is a milestone over here, Larry. Are you
milestone?
excited?
Yes. Yeah, I'm gonna put it on. It's in the books right here.
It's in the books. It's in the books. If this turns out well, you've started it.
Otherwise we'll close the book.
Yeah.
So we want to just get like a little bit of an introduction. You know who you are, kind of like your history. If you want to.
Now I will add, because I know you're an extremely humble person, so it's either you say your credentials or I'm going to jump in.
Yeah, one of us will say the credentials.
But no, I mean, I think definitely this is nice. Thank you, Mina, for inviting me. Again, this is my first time doing a podcast, so I'm excited about doing it for the first time. And
Awesome.
Again, it means a lot for me to do a podcast.
Yeah.
It's our first time too.
Yeah.
Oh no! It took some effort to get this guy to agree to this.
But this is awesome. So again, my name is Mina Rofail. I'm Director of Pharmacy Services in one of New York City hospitals. So obviously, grew up in Bayonne. I came here 24 years ago and went to Midtown School, Bayonne High School. I mean, my path to pharmacy was a little different. I didn't know what I want to do in high school,
Just like everybody else,
which is like most high school students. I just wanted a 4-year degree and just quickly finish school as soon as possible. But of course, I went into school. I went to Kane University. I wanted to do physical therapy because I didn't know what else to do. So I followed my cousin's footsteps.
Yeah.
So I was like, okay, he seems like a smart guy. Maybe
I'll just set it out for me.
Yeah.
So I started physical therapy, and for 2 years, I'm like, what am I doing? Like, there's nothing special. There's nothing that really gravitated me to physical therapy. So after 2 years of my school, pharmacy school, I said, it didn't feel right. So I called one of my cousins, and luckily he went to LIU, and he told me about pharmacy, and I'm like, you know what? He's like, apply and see. So I'm like, okay, let me just apply and see, and we'll see what happens. I never, for once in my life, thought about pharmacy, and I said, you know what? Let's just see what happens. And I left it up to God. I said, if God's willing, if this is the right career path for me, then I'll get accepted. If not, then I'll just continue with my path of physical therapy. So anyways, on my birthday, I got accepted with a $40,000 scholarship.
There you go.
It's phenomenal. There you go. You just wanted to get accepted. You got 40 grand too.
40, exactly. So I'm like, for me, it was a clear sign.
Yeah.
So of course, I started pharmacy school, and I think just surprisingly, shockingly, I loved it. And I was like, wow. I mean, I think never in my life that I thought about pharmacy, and I just started liking it. And thank God, I mean, with the grace of God, I did well in school. I think I graduated third in my class, which is really impressive. But it just shows that how much I enjoyed studying for it. Actually, I built my own little study group where, and I think they'll vouch for that, is I used to study for my exams ahead of time, and I would come and tutor my friends and teach all of them. So study ahead of time, so study extra hard, and then teach them right before the exam. And luckily, every single six of the girls, everybody graduated, obviously, but the 6 people that I used to tutor all the time, they're all pharmacists.
Oh, that's beautiful.
Yeah. So just incredible.
That's awesome. You actually touched upon a point that I feel like every high schooler and every college student goes through, which is not knowing what career path to go through. And I noticed that you also mentioned that you just ended up choosing something that you felt, you were influenced by either a relative or whatever the case was. What kind of advice or what type of advice would you give to somebody who is similarly feeling the same exact way? They can't figure out what kind of career choice. They're kind of just following the path of somebody who's influencing them. What kind of advice would you give them?
I mean, I think just following what I did, to be honest, I think maybe just a little bit, I prayed. I said, if whatever God has in store, I hope God steers me in that direction. And I think God will put things in place in front of you or people in front of you that will steer you in either direction. But of course, you have to and you have to recognize this. Hopefully, this sign, and if not, then I think at the end of the day, it doesn't matter which career you end up doing. I think one of my cousins, and I think it's inspiring, said it doesn't matter what you end up choosing as long as you try to excel at what you end up choosing.
Yeah.
So no matter what career path. So if I went to engineering, I want to make sure I want to be the best engineer that possible.
Because that's the whole point, right?
That's the whole point. So I think at the end of the day, I think there's people that have a clear decision and a clear choice early on, and they decide that very early, and I think that's really great for them. But unfortunately, I think not everybody has that luxury. So I think two things. I think obviously listening to seeing what signs in front of you, God is placing in front of you to choose a particular career, and if not, then I think just go with what you see yourself fit the most, and no matter what that is, just make sure you're the best at it.
Sorry. Already from the beginning of the podcast.
So you've been in the field for a while. Now, what was my LinkedIn stalking is correct? 07, like around 07.
Yes, I graduated actually in 2009.
2009. Okay.
Yeah.
So then, so that was you intern? You did an internship
in
right?
New York Presbyterian.
Yeah.
At fourth year pharmacy school. So that was in 2007, February 2007.
Gotcha. And now, how different was pharmacy then compared to now that you've seen?
It's really different. I think obviously there's so many things that I'll talk about. I think the first thing is when I went to pharmacy school, there was a mass shortage of pharmacists. So I still remember orientation of pharmacy school. They said, I still remember verbatim what the professor says, do not be fooled by all the sign-on bonus that Walgreens is going to give you and CVS is going to give you. Because at that point, if you were to graduate, you'll probably get a BMW and people will be fighting for you because there's just a mass pharmacy shortage of pharmacists. And of course, that changed now very quickly. Yeah. So I think that's number one. The second thing is obviously it wasn't the pharmacy was. Of course, there's a lot more novel treatment now. I think obviously there's a lot more research that was done, and pharmacy has, especially in the hospital field, has taken on a much more significant role than it used to.
So the perception has changed.
The perception has changed. I think we're now a legitimate part of a healthcare team. Before it was just a special add-on. But right now, the medical team does not round without a pharmacist. So most hospitals, the clinical pharmacy program, you actually might have a clinical pharmacist specialist on every single part of the team.
And what made that perception change? What was the missing link before that perception change that made them bring on pharmacists?
It's just, I think, what pharmacists bring to the table. I think before it was just medical doctors rounding and with nurses, and of course they saw the value that pharmacists brought to the table when pharmacists joined rounds and actually made recommendations. Of course, when you think about doctors, they only study one semester of pharmacology. We study about 4 years of pharmacology.
Yeah, that makes sense.
So I think, and obviously we use research. So I think we know the pharmacology really well. We know the therapeutics. We know the clinical trials. We know evidence-based, obviously, medicine. And we know the pharmacokinetics of the drug. We know the pharmacodynamics. So I think we bring a new aspect to the team that most have not thought about before. And it's not just starting therapy. So what stage of therapy is it in? What dose is appropriate? Do you monitor levels for this patient, or do you titrate on? Do you titrate off? Maybe it's not their best. If the patient's experiencing side effects, you don't always treat the side effects. Maybe the side effects is due to is a single treatment, and maybe you have to cut that off instead of treating the side effect. So I think it just mere examples, but I think it's just they just saw the value that the pharmacists bring to the table when they're part of a multidisciplinary team.
And now you're on the director of pharmacy. And so what does that mean? What does director of pharmacy mean exactly?
So director of pharmacy, so I oversee all pharmacy operations. So I think in the world of pharmacy right now, it's actually split into two parts. So there's a clinical pharmacy and there's operational pharmacy. So clinical pharmacy are the clinical pharmacists that round with the teams. Operational pharmacy are the pharmacists that actually verify the orders for admitted patients. So when patient gets admitted, the providers writing orders. The pharmacists are the ones that actually check and make sure that the orders that the provider ordered are appropriate. There's no allergies. The dose is correct. The patient doesn't have any contraindications to that medicine. And then once, if the pharmacist sees that this drug is appropriate, they verify it. Then a label generates. Then the technicians fill it. They prepare, if it's an IV medication, that they prepare in an IV room. That pharmacist checks it, then delivers it to the unit. So that's the staff pharmacist. So I oversee that aspect of pharmacy. So the staff pharmacists who verify the orders, who compound the IVs, who deliver the meds. But of course, so I oversee that aspect. That's just one aspect of pharmacy. Of course, I also oversee control pharmacy. I oversee the storeroom. So purchasing. I oversee, I said compounding, and I oversee like the production, just mass production of like repackaging meds and so on and so forth.
Gotcha.
So that's what I oversee as a pharmacist. But I think as a profession, I just of course I never thought one day that I will be at this point. Obviously, it's all through the grace of God, but it was just a journey that got me to this point. Like never once that I thought about me being an operational director, because I always wanted to be on the clinical side of things. But it just shows you God
took a leadership road.
Yeah, exactly.
Now you've explained to us your job description. Now we've got a good idea of that. But has anything changed on the list of your responsibilities or anything under that umbrella when COVID hit?
Oh wow,
that's the can of worms, right?
Yeah, yes, that's a very loaded question. So definitely, I think. So obviously, I think just like the rest of the country, we didn't know what we were about to get. Of course, I think everybody, I think from lower level leadership to even the CDC, we didn't prepare correctly, right? We didn't have enough testing. We didn't have enough PPE. We didn't have enough drugs.
Larry was actually telling me that Bill Gates in 2015 had said something.
So he had a TED talk about how the world wasn't ready for a pandemic. So that, I mean, I want you to finish, right? But then the added on question is, from 2015, is that characterization correct from where you were working? And sort of why was that the case?
Yeah, I mean, absolutely. I mean, I think we saw it firsthand. We were not prepared. And I think even the president of the United States, I think the only thing he thought about, I mean, not to criticize, but I think the only thing he thought about was like, okay, let's just shut the borders from China.
Yeah.
But not knowing that at that point, it was just so widespread.
Yeah.
I think the biggest thing that hit us in the face was we actually had the very first patient in New York City. And when that patient came in, actually he came in as a normal patient, just came in with symptoms that we were like, okay, we'll be treating pneumonia. So they came in and gave him antibiotics, just like you treat a pneumonia case.
Nothing was working.
Nothing was working. So like, okay, and he started decompensating. Like, okay. So of course, patient had no travel history.
Yeah.
So we didn't suspect at all that it's COVID. But then after a few days, when we thought that he was decompensating, we're like, you know what, let's just do a test. So when he tested, it came out positive. Of course, there's like a mass hysteria. And obviously, everybody that on that ward, on that nursing unit, was actually exposed.
Yeah.
And without the proper PPE.
Yeah.
So of course, actually, that whole workforce, that whole nursing floor had to actually be quarantined. Yeah. Which was incredible. So now you take out a huge chunk of your workforce. So of course, I think that hit us right in the face, because this patient didn't travel recently, had no history of travel or anything. So I think we're like, oh. Then we started seeing more. So now that one patient went to 4 to 6 to 15 to 100.
It was at that point that you realized that COVID's already been in the
It's
country.
just so widespread that it's out in the community, and then we just lost control, and it was just an avalanche.
Now, we're not new to novel viruses, right? Especially in your time at the hospital. Now, how did this compare to like H1N1, where 60 million, I think, Americans were infected?
Yeah, I mean, I think this one is, I think, unique because of, I mean, I'm not obviously I'm not in epidemiology or ID specialist, but I think what makes this one out of control was just how the rate of contagion. Like it's just super contagious. And then of course we didn't know anything about it, and I think we're still learning, and I think that's why maybe we're hopefully getting better, and I think that's why we see the death rates decrease now. But just I think the level of just how contagious the virus is, I think what makes it unique. And I mean, I think we're still sometimes, even the CDC goes back and forth. Is it airborne?
Yeah.
Is it?
At one point, they thought it needed to be aerosolized.
Yeah, it's aerosolized. So now we're like saying it's both. It's droplets and it could potentially be airborne, and that's why we're recommending.
Now so compared to like H1N1, so when that came in, right, what was the difference in preparation? Well, so I know it wasn't as infectious. Now, was that the key factor in terms of preparation to deal with that virus compared to this one? Like, why was it that this one created more of a hysteria than when we went through swine flu?
I think just due to the fact of the rate of transmission that we saw, and I think.
Were the treatments different, like in terms of how we treated swine flu at the hospital?
The treatments were different. Obviously, every time you have a virus, it's supportive care. So you don't have. It's really hard to get an antiviral that's really effective, and that's I think right now that's what we're struggling with.
Yeah.
Because every part of the virus mutates really quickly. So I think that's what differentiates it. But I think also with coronavirus. I think the level of sickness, how severely people got sick was just, I mean, one of the clinical pharmacists, she worked for 10 years. She's obviously the sickest she's ever seen. So patients come in from day 1 to day 5, they're doing fine. All of a sudden, from day 5 to day 7, you don't know what happened. They just their lungs completely collapse. So the rate of, I remember the amount of IVs that we have to make was. We have to batch close to 1,000 IVs a day, so extra on top of what we were doing. The patients were flying through. So vasopressors, which is just to keep just pretty much supportive care, just to keep your organs running and your heart pumping. They used to fly through those bags and those doses because they just completely collapsed. And I think that's why, and I think it's just something that we haven't not seen. We've never seen it in the past.
Yeah. Like Ebola was a big deal, but like that never really hit here.
Yes.
So that wasn't as much of a...
Yeah, Ebola didn't hit here. So of course, and I think, and that's why it was, even if we had a few patients actually in Ebola, we had one of our hospitals to be the designated center for Ebola, but we were able to control it. There's just a small site. Here, it just went so widespread that we didn't have enough resources to contain it.
So was there ever a point where the supply was much less than the demand?
Yes, and I think everything, right? So I think it starts with testing.
Okay.
We didn't have enough testing. So make the long story short, I was actually in March 15th, I got symptoms of cough. And so I had a little sore throat and I had a fever. And the next day, I went to work and I'm like, I had this huge migraine, and I said, wow, I'm not feeling well. But of course, we had a 7:00 a.m. that we had to be there. We had to be on a call because this is March 16th. So this is, if you remember, like it was March 4th. We're like, okay, first one patient and a few patients, 11, and then March 16th, it's like
exploded.
Yeah. Right. So I remember the Sunday night before, our VP called us and said, we need you guys all on a 7 a.m. call, because we need to plan for this virus that's about to hit us. And so I went in and I couldn't even, the migraine was just so bad. And so after the meeting, I had to close the door and I had to sleep in my office because I was just so tired.
Mm.
So I went to employee health. So I'm like, you know what? I don't feel well. So I went and so I told them what my symptoms were. I said, I have a migraine. I just have a sore throat. And I had a fever. And they're like, well, anyways, we don't have enough COVID tests. So what we're going to do, you don't sound like you have the hallmark symptoms of COVID. We're just going to test you for flu PCR. So they did the nasal swab for flu, and they said, why don't you go home, and then we'll call you. So I went home. I called my VP, and she freaked out. So I said, well, don't worry. I think they don't think I have COVID. But anyways, I'm like, but they didn't test me because they didn't have enough testing. So that 2 hours later, I went home, and of course, I walk in my wife at 11 o'clock in the morning, and she's like, what did just happen? I said, I'm not feeling well. And of course, there was this big stigma, and obviously it was just this chatter. And I'm like, well, I'm gonna get tested, and we'll see. So 2 hours later, they called me and they said, your PCR is negative. Ooh. But for flu. So I said, okay, perfect. So I told my wife, I told my mom, I'm like, I'm okay.
Did you know it was only for flu?
Yeah.
But doesn't that narrow the options that it's COVID?
So and that's why I'm like, they weren't testing anyway because they didn't have enough testing.
Yeah.
So anyway, so I said, so that was Monday. Tuesday I stayed home. I said to and Wednesday I went back to work because you know what, things are happening so quickly at the hospital where I'm actually needed. Anyway, so I went back, and thank God at that point they're like, okay, you have to wear your masks, and it was universal precaution because even that was not. We were trying to save masks, and we were telling everybody not to wear masks.
I remember that.
Yes, and save the masks only for nurses.
Yeah, low supply.
Yes, low supply. So, anyways, a week later, my wife starts losing her sense of taste and smell. So we just knew. So, anyways, long story short, I got the antibody test in May, and of course,
you had the
surprise, I was positive for antibodies. So that's one thing that we didn't have enough.
Yeah.
So we didn't have enough testing, which is really hard to contain a virus of this kind. The second thing we didn't have is we didn't have enough PPE. And the third thing is just the supplies, right? Medication supplies. I think at one point we had a pallet of propofol, which is a popular sedative, and you needed to sedate those patients because most of them were on ventilators. And we flew through it in maybe in less than 10 days.
And where do you get these supplies from exactly? Where does the hospital get them?
I mean, from the manufacturers. I think obviously we go through our wholesalers first. And at one point, the wholesalers are out, and we had to actually leverage our name, and I think our hospital our size with the manufacturing. We told them, we are one of the largest hospitals, and we have the epicenter
of COVID. Yeah.
And is that standard protocol, or is that how it's not supposed to be? The fact that you had to compete for those supplies, essentially.
I mean, that's when all else fails. When you can't get the medication elsewhere, you have to pretty much pull your muscle a little bit. And get. I mean, I think luckily, and we have to be flexible with the treatments. We have to choose based on what we have and based on what we can get. That's what we were able to give the patients. I think for the most part, I think we did well. We never even if we ran out of one med, we had an alternative. Maybe it's not the best alternative, but it's the best available out there. So I think we lucked out. So anyways, fourth thing, we didn't have enough ventilators, right? And which was
that was a big deal. Yeah,
that was a big deal. And I think what helped us and I think some of the other hospitals is we started using the anesthesia machines. So the anesthesia machines that they use during surgeries, since surgeries,
you can use it for air.
Yes, to ventilate patients.
Yeah,
and that's what saved us.
Very creative.
Yeah.
Yes. So definitely we weren't prepared from. Obviously these are the four things, but just in general, and obviously. The other thing that we didn't have enough of, we just didn't have enough ICU beds, and we didn't have enough beds in general. So for example, and I think it's something that actually Andrew Cuomo said. They said we had about 900 ICU beds in New York City, Actually, I maybe don't quote me on the numbers, but we needed at least 10 times of that number to get it.
Yeah, I remember that in his conference. Yeah.
Yeah. So anyways, it pushed us to the brink. Actually, so I think the best thing that the government had to do was they canceled elective surgery, and we ended up turning our OR beds into ICU beds. So we converted all of our ORs to ICUs. But of course, it's easier said than done, right? It's easy to say, okay, we'll stop surgery and we're going to convert to OR. Well, where do you get the supplies to make it a negative pressure room, right? Because I think anytime you have a virus, you can't have air come out. So you have to have that right engineering to make it a negative pressure room. You have to have the resources, and also the personnel, right? The personnel that's the nurses are in the ORs are OR nurses. They're not ICU nurses, so they're not trained to take care of.
But you need as many heads as possible.
Exactly, ICU level patients. Same thing with even our OR pharmacy. They're not ICU pharmacists. They're not ICU pharmacists, but now they're trained all of a sudden to be trained to verify OR patients. Our OmniCells, which is the automated dispensing cabinets where we keep the medications in each patient care area, we didn't have the right supply because those are again OR ICUs, so you have to convert. So it was just so much coordination. I think obviously we needed to make sure we had to do things on the fly. The second, and also another thing the hospital did to just free up room is we pretty much every conference room. So if you had a room like this,
this would be turned into an ICU or something.
Yeah, this would be turned into
That's crazy.
A patient, either an ICU or so. All the conference rooms, we had to convert them to rooms. So any room pretty much that we were able to get on our hands on, we were we converted. I mean, the last thing, and you saw probably in the news, is we had to make like field hospitals.
Yeah.
And so we had one stadium, and we just converted to a 300-bed facility in like record time. And actually, at that time, we didn't have enough resources, so we actually had to rely on the military. So it was military staff that had to staff. So we provided medications. We would verify the orders, but it was military nurses and military physicians. So just incredible.
And I'm aware that it got to a point where they actually sent out the Mercy ship.
Yes.
Do you feel like that having that ship there assisted? Because there was a lot of talk. Obviously, politics gets into this, but putting politics aside, did you feel a strong presence or assistance outside of those who already were part of the hospital system?
We didn't. I think the way it started, Mercy Hospital. I think Mercy Strip. I think it was Mercy Strip. Their criteria was they wanted to treat only non-COVID patients.
Oh wow!
So that's initial. Okay. That changed over time.
Okay.
So initially,
what was the strategy in that to free up the hospital of non-COVID?
Exactly.
Okay.
So anybody that's non-COVID, so this way you don't so you keep the hospital focused on COVID patients. Okay. You take anybody that has like any other complaint in MERS. So the protocol. So they come first to our hospital and like, oh yeah, well, you're not suspected of COVID. Okay, but why don't we transfer them? So I actually our hospital is part of the hospital. We worked with the ship, and we actually were able to provide some of the medications necessary to transfer them. So if they needed, so we used to give them like a couple of days supply until they get to the ship. But anyways, that at one point we're like, you know what, that's not helpful. We actually were so
assistance with COVID.
Yes, we need assistance with COVID. Yeah. And I think, and I'm not sure if also I didn't follow the news, but I'm not sure if anybody, because also the thing with COVID is you might test negative now, but 2 days from now,
the incubation period.
Yeah, exactly. So anyways, I think eventually they started taking COVID patients, but then I think luckily the numbers started coming down a little bit. I mean, I think if we can, I think our peak. So I think we started March 16th. I think until like first week of May 4th, we were like, oh my God.
Was there a decline in non-COVID patients at the hospital from when it was peaking till now, even till now?
Definitely. I think the reason why was obviously people are scared to come to the hospital.
Yeah.
And second thing, anybody that has something that can wait, make sure they wait.
Like, this really wasn't that serious.
I'm sorry?
It's like, this wasn't really that serious.
And especially also, like, I think shutting down, or I guess suspending elective surgery was huge, because that also generates a lot of traffic. So anybody that's doing hip or knee or any of those surgeries, they can wait. And
like, you would need staff for that surgery, and you wanted that staff towards other things.
Of course. So I think, our numbers are still down. I think they definitely picked up. I mean, at one point we were at 50% census.
Oh, wow.
But I think our whole entire census was just COVID. 90% of our hospitals COVID. It was just incredible.
Yeah, that's so. I mean, what to call it? You wanted to follow up, or I can move on to the treatments for COVID. And how are they different from the first wave, and how are they in terms of what they are now? So from first wave and now, how are the treatments changed? So if I went to the hospital, God forbid, with COVID, what would be my treatment different from the first wave?
I think the first time around, it was supportive, right? Because we didn't know anything about the disease. I think we would learn about, if they did a study in Italy on 6 patients that got hydroxychloroquine.
Yeah,
you would try hydroxychloroquine, and then there was another study where 4 patients got hydroxychloroquine and a Z-Pack, and it worked. So let's try that. So we didn't know, and I think there was a study on famotidine, like Pepcid, like for the stomach, and so anybody was just, like, I think
it was experimental.
It was experimental. Everybody was, so there was no, the data out there was very weak. It was not randomized. It just. But I think anybody that did anything that worked on anybody, they just wrote a paper on it, and I think we just took that. And of course, like ascorbic, like vitamin C IV, and so on and so forth. So I think there wasn't a lot of coordination. I think we were just trying. We didn't know much about the disease. We didn't have a lot of guidance, and we used the best. I think one of the things that worked best was proning. So just those ICU patients, if you turn them every 12 hours, that was huge. And it was non-treatment. It was just huge, because when you prone the person's body, you use a part of the lung that that hasn't been used for 12 hours. So that was just
that's amazing. I didn't know that.
Yeah. So that was just one big thing that we learned early on, but everything else was experimental, and we were just trying to obviously support the patients as much as we can. So right now, obviously, we know that steroids are huge. So
how so? Why would steroids help?
Because part of the issue with COVID is obviously when your body is attacked that way, you solicit a huge immune response, which actually does more damage to your body. So steroids in general, they just lower that immune response. So this way you don't cause more damage to your body.
Interesting. Okay.
So that's steroids. So anybody now that's hypoxic, so if you have an O2 saturation like less than 60, you get steroids. We have remdesivir, which is an antiviral.
That's what the president took, right?
No, the president took a monoclonal antibody.
Oh, okay. Which one's the cocktail? Maybe not a cocktail.
Yeah.
I thought they referred to it as a cocktail, but I guess it's not a cocktail.
I think he took the Regeneron. So what's monoclonal antibodies? So it's just pretty much antibodies to help you fight. So this is actually they're under. So those monoclonal antibodies are about to be approved. They're gonna get what's called a emergency use authorization by the FDA. So this way they can be trialed on so this way the FDA can grant permission for us to use them. But I think those monoclonal antibodies, the way that they are in the therapy, is to prevent hospitalization. So you're sick, but you're not sick enough to be hospitalized. So they will give it to you so this way to prevent you from becoming hospitalized.
I see.
So that's what the president received.
Pfizer is also flexing that
Yes.
early FDA emergency.
Yes, emergency use.
Yeah.
So that's with the vaccines.
Okay.
So that's what's so that's what actually they're meeting. I think the 9th of December. So I think second week of December to review. So I think they have an immunization
Yeah, I
advisory board.
actually believe Murphy announced that we were getting 133,000 vaccines or something like that sometime in the middle of December.
So that's actually what they're going to meet about in 2 weeks. So they're going to talk about so they're going to present the data from Pfizer about the 3 clinical trials, and so part of an immunization advisory group by the FDA will make the decision based on the data that's presented in front of them, and they will make a decision on whether or not Pfizer can be granted an EUA, which is emergency use authorization, and if that gets accepted, then now it's the next thing that will get decided in that meeting is, okay, how much capacity, how much vaccines can we produce, and then if we have a limited number, then
who's going to get it?
Who's going to get it?
Which seems like it's going to be an ethical dilemma at the same time, because who do you decide, or how do you decide who gets to live or essentially not to live?
Yeah. Which is very tough. I think so far, what's expected is obviously healthcare workers first, because they're at the front line and they're the most exposed.
Will the hospital enforce it, or is it still going to be like voluntary?
I think the hospital will do its best to enforce it.
Okay.
Obviously, there's
like reason. Yeah.
You can thank the media about how and then the politics and how they actually instill distrust in the vaccine making process, which is going to be a challenge because you don't want to create this vaccine people
are worried.
Yeah, exactly. So I think that's going to be, I'm sure, a lot of the money in the media. There's $50 million, I think I was reading, that will be just allocated to just convincing people that the vaccine is safe and everybody should be taking it.
Yeah.
But of course, so I think the hospital will do everything it can to give.
Now, who do you have to talk to get that vaccine for the hospital? Are you guys in talks right now with how you're going to be distributing it once you can?
So actually, we are in discussion. So actually, we had several meetings already about how if and when this vaccine gets approved, how are we going to store it? Because like you mentioned,
Pfizer requires, or Pfizer does
ultra cooling.
The cooling, right?
Yeah, minus 80 degrees.
Yeah,
which is ridiculously cold.
Ridiculously cold.
Just take it to a cold state.
And once it's out of that deep refrigerator, it's only good for 5 days. So of course you don't want to waste any. So I think we're discussing how do you store it, how do you distribute it, how do you prevent waste, how do you count for every single dose, how do you also. What makes it also tricky is that it's a 2-dose.
Yeah, it's not a 1 dose. Why does that pose
because you have to make sure you have enough quantity. I gave a vaccine to Mina Morcos. I want to make sure that in 21 days from now, I have another vaccine for Mina Morcos when he comes back.
So there is that gap where. So is it 21 days?
21
days.
Exactly
21 days.
21 days.
So that poses its own issue.
Yes.
The fact that there needs to be the specific timing in which both doses are administered.
Exactly.
Okay.
So that's a Pfizer product. The Moderna product is going to be 28 days apart. But
that does not require the ultra cooling.
It does. I think not the same temperature. I think maybe minus 40. But so far.
Okay. So both pose an issue with the cooling. Okay.
And do you have any information about this Russian Sputnik vaccine?
Oh my God, no. I mean, I think there's about 150 vaccines out there that people are trying to market. Obviously,
yeah. That are in that last stage, or
no.
Oh, okay, yeah.
Only 5 in the United States at the clinical phase 3 trial.
Yeah.
So only 5 so far. We know the results of Pfizer and Moderna. AstraZeneca came back with the results, but of course, I think people are worried because obviously they were very transparent about they had to stop the study at one point because one of the patients I think died, and but of course,
okay.
but of course it can be it wasn't attributed to the vaccine. That's why they restarted the therapy. But of course, but anyways, I think that's also AstraZeneca also proved to be effective.
Now,
So
when they're saying that these like 90+ percentages, right? Now, from my brief understanding of statistics, that's based off the size of the group that they had. Now, obviously, when you pass it on to hundreds of millions of people,
That can change.
You know, how drastic are we going to see that number change?
Yeah, I mean, I think it's remained to be seen, but I think the one thing that was very noticeable in the study, Pfizer and Moderna, is that even so, I think let's just talk about the Pfizer for a minute. So I think 90 patients in the placebo group got COVID. Only 5 in the treatment group got COVID. So they're saying even the 5 that got COVID, it was a much less severe case. They experienced less severe case of COVID than the others. So even if it doesn't protect you 100%, even if you still get COVID, chances are you have the antibodies that you've created from the vaccine will hopefully have a less severe disease.
So the 90 were severe. There were severe instances of COVID, more severe.
Yes, versus the 5. So you got COVID, but
in comparison.
Did
they incorporate people with pre-existing conditions?
Yes, it was randomized. They did.
Now you did mention one of the hurdles we're going to go through is the transmission of the vaccines or transporting them and spreading them out. Now, obviously, politicians are saying that we would use the National Guard and the military to transport that. How do you see the hospital system and the military working together in order to both apply and administer the doses as well as try to get the vaccines everywhere that's possible?
That's going to be a huge challenge, a huge logistical challenge because of all the things that we've mentioned. I think they're going to probably use all hands on deck. And that's why I think even then President Trump at one point, they were going to say they're going to use the Walgreens and the CVS's and like any major organization out there that can help with the distribution of vaccines. I think that remains to be seen. I think it's going to be a huge challenge, but I think that's what we have at the table right now. I mean, I think it's going to be a problem until that's figured out. But I think once we have a system that works, I think it's going to quickly spread. But yeah.
Are you familiar with whether there's any type of unique method with administering the vaccine, or do we need a special person? Does it need to be a doctor? Can it be a nurse?
No, yeah, it's just a regular vaccine.
It's just an ordinary
just
vaccine.
A muscle, you just get it in the muscle and just a regular vaccine.
Okay.
The vaccine is unique. I think it's an mRNA vaccine.
It's a messenger,
Yeah, messenger.
I remember this from bio
class. Yes.
Finally.
Which is the first of its kind.
Yeah, so this actually goes to another question that I wanted to ask you. And although COVID comes with a ton of negatives, right? But there are also a few positive. Like, for instance, you started off by saying we weren't prepared.
Yes.
I think from now on, we've learned our lesson.
Yes.
I think the U.S. has both realized that we're not prepared medically, but also when the government shut everything down, we're not prepared financially. We're not prepared resourcefully because we were getting everything imported. So do you see COVID being some type of light at the end of the tunnel for innovation or a change in how medicine is done?
I think it forced us to. We there was no other way to come out of this pandemic or survive this pandemic without being innovative and resourceful, and I think just thinking outside the box, and having our guards up at all times. I think if you talked, and I think that's why, to your earlier point, when we talked about Bill Gates and when we talked about even President Obama mentioned it, like nobody believed them, but
the whole pandemic team and everything. Yeah.
So I think right now, I think our guards are up, and I think so. This pandemic definitely forced us into many positive things to come. So I think a lot of positives have come from it.
Now, I cut you off briefly. You were about to go into mRNA. So for those who don't know what mRNA, let's hear that bio lesson.
Oh, I don't know if
because
I
it
can
is
remember.
very, very interesting.
Yeah, I think obviously I've been out of school for a long time, but the messenger RNA is so one of the RNAs, one of the types of messenger RNAs. So it goes into, so the way this vaccine would work is it actually, when it injects into your body, it's like a USB cord. It just starts activating things. So the way it works is it spits out the messenger RNA, and it produces something called a strike protein, which is what the coronavirus uses to enter the cells. So that's the only thing that we can make the vaccine out of, because I think anything else for a virus would mutate. So you don't want. So the only thing that doesn't mutate is that protein. So I think it gives instructions. It gives messages to create those strike proteins. And then now your body sees this as something that's foreign, and it creates antibodies against it. So, and then now the next time you get exposed to coronavirus, your body has already the antibodies that.
So is it mimicking the response of
Yes.
So it's not actually COVID that's going into you?
It's not COVID. So just like most vaccines, the novel vaccines are either a weakened or a dead version.
Yeah.
This one is not. This one it mimics how COVID. It mimics the protein that COVID uses to enter. And
is this like a new process, or is this precedented?
No, we've been talking about it for 2 decades, and we've never actually.
Also, this is the moment that we're actually going to get into it. Okay.
Yeah, this is going to be the first of its type.
And what's the promise behind this methodology compared to what we've been doing before?
I mean, I think we've been wanting to do it for the longest time, and I think we just haven't. We didn't see the need. I think the necessity that we needed to use this model also because of the speed. So usually a vaccine process to an approved vaccine, it's like usually an 8-year process.
Yeah.
We made it in 250 days.
Yeah.
So it's just unprecedented. So I think it had to be done this way.
Oh, is this what cut the time?
Yes.
Okay. That makes a lot of sense.
Because I think the only thing you needed here was just the protein sequence. And as long as you know the sequence of the coronavirus, and that's what you had to mimic. So it was a lot easier to prepare, and I think we can make it in mass quantities much easier than the other vaccines.
I see. Okay. That's
now we keep hearing this phrase, the new normal, and honestly, every time I hear this phrase, it kind of terrifies me, because I like the way things were before.
I know.
Now, do you see us ever getting to a point where, as if COVID never existed?
It's going to take a while.
Do I have to go to Walmart with masks?
Oh my God.
In a year.
I think until we are able to vaccinate the vast majority, 80% or more of the population, I think we may have to still wear masks. I mean, I think there's going to be a lot of people out there, that's going to be the point is, there's a lot of people out there that will not take the vaccine, unfortunately we will not be able to eradicate COVID.
Yeah.
So there's still be people that will still get infected, and still people get unfortunately sick and potentially die. So until we get to a point where we have the majority of the population vaccinated, then we will still have that. I think the new normal thing you mentioned was just funny, because I remember the CDC in February came out and said something to the like of, get ready, COVID will change the way you live. And then when everybody heard it, they were like, what are you talking about?
Little do they know. Now we're reflecting back, and we're like, yeah.
So CDC doesn't just make random. So I think it caught our attention. I'm like, okay, let's do it.
Yeah.
So that's why when the CDC said there's gonna be a second wave, we're like, oh, there's gonna be a second wave.
Yeah.
So I mean, I think things will continue to get better after the vaccine, but I think it'll just take a little time. I mean, I think I mean, I think we're already probably talking about 2022 at this point, where we hopefully start seeing.
But that's an
normalcy.
interesting predicament, right? Because if someone doesn't take the vaccine, right, they elected not to, and then they come to the hospital and they're sick, then what are that you can't give them the vaccine at that point, because obviously everything is permission based, right?
Yeah, it's
so you have to use any other treatment.
Yeah, because you are already infected.
Well, is the vaccine a treatment or is it a
Preventative.
I see. So the vaccine
So
won't work after.
regardless,
Okay, I see.
Yeah. So I mean, the whole point of the vaccine is you can get the antibodies built before you get COVID. But obviously, when you get COVID, you're already making the antibodies. But of course, your immune response and I guess depending on your conditions, it might go south or you might be okay.
So in terms of the current, what we're currently doing to treat patients with COVID, do you think that there is anything that we can improve on, or are you seeing cases, people are coming in and they're leaving the hospital COVID-free or in a much better case than they entered?
Yes. Actually, it's very interesting. The death rate of COVID has significantly went down. So actually, we have this nice article that I think our hospital leadership showed a few last week, where even by age class, some age group, and if you're like less than 49, your death rate almost went to like almost zero, close to zero.
Oh, wow. That's amazing.
But everything else, we want from like maybe 50%. If you're over 85, you want from 50%. So 50% if you're 85 or older. Now we went to 12%.
And when you say 50%, was that first wave percentages?
Yeah.
Okay.
Yeah. If like some of the other patient population from like 49 to like 65. So we went from 25% to pretty much like 6%.
That's beautiful.
So I think I want to say with a couple of exceptions, our death rate was slashed by 4 times.
And that's due to new treatments, or just because there's less load on the hospitals?
Both.
Okay.
Both. Also, the length of stay, how long they stay in the patients. Also, that's went down by also pretty much 4 times. So the average length. So the ICU patients, you were staying 16 days. Now you might be in the hospital for 7 days. If you're not in ICU, now it's up from like 7 days or 8 days. Now it's like 3 days. So the patients. The patients are doing much better. They're staying much less. And the death rate has significantly gone down.
When you were going through those experimental treatments in the first wave, were the hospitals in communication with each other on trying to help each other out with, do you have a WhatsApp with us to talk about what's been helping, what's not been helping?
So there's definitely communication was across all the sites. So actually we used to have, as a pharmacy department, we used to have a daily call with all the New York City hospitals. Like at 5:30, you call NYU and St. Mount Sinai and New York Presbyterian, and every leadership from around the hospital would talk to each other about how is there anything that's working. And I saw a lot of things that's published. So I think that's why people were publishing things really quickly. I still remember one of our ID pharmacists was staying home. She was staying home. She was staying in the office really late. I'm like, what are you doing? And she's like, no, I just have to get this out. And actually one of them was coming out even when our phase, when we got better in New York City, and now we saw spikes in Texas and Florida and Wisconsin. We're like, no, we have to make sure we publish this way other people around the country.
That's awesome. That's beautiful.
Yeah. So definitely everybody spread everything. We spread the knowledge.
So the communication was better, put around when it was actually research that you guys were putting out.
Research and sometimes it doesn't have to be as official. If there's something that's out there and you have yet to publish it and you think that information is critical, then you do that. But I think for the most part, it was done through research.
I see. Okay.
So one of the biggest ways that we're kind of fighting against COVID, and New Jersey specifically, we're starting to see the repercussions of the second wave. We're starting to see cases going up. is having more testing, and we're starting to see these take-home tests. I kind of wanted to get your stance on that. What is the both efficiency and reliability of getting a test like that? And from what I'm aware of, those like 15-minute COVID tests, you get your results immediately. Those aren't the most reliable or the most accurate. So what do you think of these new take-home testing kits?
I haven't read much about them, but I know that that I think the FDA is about to approve one, and I think which will be huge, because you just see it. Like, I think you hear stories about people standing in line from 7 o'clock in the morning to 3 p.m.
Yeah, tell me about it.
Just
So, City MD. Oh my God.
So I think that will be critical, and also those people that are standing in line are also exposing other members.
Yeah.
So I think that will be critical. I think my take, and I think it's a limited take on this, because I just haven't done a lot of research on it, but I know if the FDA approves it, then that means it's worthwhile. I think it will be a big hit, because I think that's what we'll need at this point.
Will the hospital just get it before like the layman?
Well, no, I think you're talking about home testing, right?
Yeah, home testing.
Okay, so what about the rapid testing? I think those were like the 30-minute tests.
Oh
where
yeah,
you'll find out the
yeah.
response.
So I think when I got my antibodies, I got my result within 2 hours. So yeah,
wow.
Yeah. So, but of course, it takes a lot of money, I think, and to spread that across. I think rapid testing, I think, will be indicated in some areas, but I think it's probably. I mean, again, I'm not basing this on anything, but I'm just saying, just the sustainability and to spread that everywhere. I think we'll continue we'll have a lot of.
Is that more likely to be a part of our world instead of locking down everyone at home? It's just the availability of like just quick tests. Is that just going to be the better solution than keeping everyone at home?
Well, I think we'll have to. I think the rapid test will have its places of use where you would need to have rapid testing. I think for the others, I think whatever way of testing is the way to go.
Yeah.
So but of course, I think it'll come in different forms, and I think in different turnaround times based on I guess the venue, or based on I guess what the situation is.
Now, do you guys game plan? Not game plan, maybe not the right word, but do you guys look ahead as to, how things will be different policy wise from the new administration that will be coming in January? Now, is there, is it kind of like you just, go as, every day, like we'll figure it out when the day comes, or are you looking ahead to their policies that may affect the hospital or anything, or in terms of COVID related?
Yeah, I mean, obviously, I think the promise is that they're going to be a lot more, they're going to spend a lot more resources and obviously time and money into COVID and I guess controlling the pandemic. Obviously, as a new administration, they're going to try to prove that the previous administration hasn't done what it can do. So I think nothing really specific that I know of. I know everybody's talking about the whole like mask mandate, a universal mask mandate for the whole country, but that remains to be seen. But in terms of, obviously, they're going to be heavily involved with the vaccine production, distribution, just making sure that everybody has free access and easy access to it. But nothing.
It's all speculation at this point because nothing is set in stone.
Exactly.
Yeah. Okay.
And speaking of the new administration, it's no secret that they're more inclined to shut down the country once again. Obviously, the country at the moment is extremely divided for many reasons. And I think in politics, regardless who the politician is, their constituents will never agree with them. There's always two sides. There's always different opinions. So there are those sides that are like, okay, it's either we die from COVID or we die from starvation, because we've seen an influx of businesses going out of business and selling and because of the shutdown. So what, from a medical standpoint, what do you think would have been the best approach? You understand a lot of people said younger people are less vulnerable, so possibly allow younger people to go out. But then again, younger people can also pass on the COVID to their parents or people who are much older. What's kind of your stance on the government's role or advice, medical advice you would give to a politician on how they would be able to run their state or government?
I mean, I think it's really tough. I mean, I think unfortunately it doesn't go hand in hand. You either shut down a country and control the disease, but also that has also a lot of ramifications down the road. It's really tough. I don't think there's a really good answer out there, and I think that's why everybody's struggling with it. I think we saw many different types of ways that the government has dealt with this virus. I think maybe New York now, even though it was highly criticized in the beginning, I think New York is actually, even though now we're heading a second wave, we're not seeing the numbers we saw before. So we don't have a double spike. But you see other states like Florida, where like, okay, you know what, nothing's going to happen.
They were a lot looser.
So I think it's a fine balance. I think I liked what Governor Cuomo did is he went by data. He used specific guidelines on what the cutoffs would be for expanding the reopening. So I think that would be. I think it would be a combination between just science and making sure that you open as appropriate. So I think you're conservative, but be also allowed. You can't just shut it down. You have to be conservative, but you also have to use science and data to support your decisions.
So let's end on a more positive note. What's your light at the end of the tunnel now? Like, what are you now looking forward to? What are you excited about?
With COVID or?
With COVID or in general about, your field, your hospital and everything.
Yeah. No, I mean, I think with COVID, I think the vaccine is the end of the tunnel. I think we waited. That's our way out. That is our end of the tunnel. So I think obviously we just have to, as long as we get over the barriers of people being afraid of the vaccine, I think that will be huge. And I think hopefully that's probably our earliest bet to come to potentially going back to normal life again.
How do you think we restore that trust?
It's going to be, obviously you always have your anti-vaxxers, which is those existed before.
Yeah.
And then you also have how like some of the politicians talk about, they just some people believe anything a politician would say. Like if you're a Trump believer and Trump said something about the vaccine, then you won't take it. And unfortunately, just some people will just blindly listen to that. So I think there's going to be a lot of effort from the media, from the government, from like from pretty much from every single like organization to try to just get the message out that the vaccine is safe and vaccine is effective and the vaccine is the best our answer to getting back to normal life again.
Right.
So and I think just the 3 W's I want to end with is wash your hands, watch your distance, and wear your mask. So the 3 W's.
Beautiful. You heard it here.
You heard it here first.
Thank you, Mina, for being a part of this historic first episode. We really appreciate having you on. And this was amazing. This was a lot of content was able to be consumed out of this. So.
For sure. Thank you so much, Mina. And to our listeners, thank you so much for watching and listening. And it's best to take this all and try to relate it in our lives so we can get out of this COVID situation.
Perfect. Thank you.